talking about induction of leukemias. So acute leukemia induction, as we all know, is followed by post-induction therapy. And as we know, for ALL, we have a different type of strategy post-induction, which is usually consolidation followed by maintenance, which goes on maybe even for 2 years. And for the AML patients, we usually post consultation, there's high dose therapy followed by stem cell transplant in the high risk patients. Over the years, as we know in AML, there has been a progress, though it is slower than that in ALL. Definitely, slowly we are progressing, and now overall it's around 60 to 70% of the patients do get long-term survival even in AML. But as you can see in this graph, as you can see, overall there's nearly 88% cure rate in childhood cancers, but still the acute myeloid leukemia comes way low in the list of curability. So definitely there's a lot to be done in this malignancy. And as we all know, AML is a heterogeneous disease, it's a difficult malignancy to treat, requires excellent supportive care, blood platelet transfusion, higher antibiotics, antifungals, finances, and this is especially challenging for the low and middle income countries. And because of this, in many of the LMICs, there is high induction mortality, there's morbidity, delays in treatment, and even post induction deaths. And as we all know, allogenic stem cell transplant, though standard of care for the intermediate risk and the high risk AMLs, this is not an option in most centers in India and other LMICs. Definitely, newer therapies are coming, and maybe we'll talk about that in the next few slides. But to talk about AML, let us talk or start with talking about acute lymphoblastic leukemia. As we all know, it is a true success stories of childhood cancers. And as we can see here, nearly 95% of the children, especially in the developed countries, are now having long-term cures with this malignancy. But very importantly, as we know, even till some years back, when the Chaptis group actually did try to decrease the maintenance therapy to 6 months of maintenance therapies, we saw that the event-free survival decreased to less than 60% in their group of patients. Not only that, if you see overall, even when we had decreased the maintenance therapy from 2 years to 18 months, there was an increased or a decreased event-free survival in this group of patients, letting us know that maintenance is an important part of treatment in acute lymphoblastic leukemia. Again, to talk about it from the other side, as you can see that those patients who are MRD low continue to do well in most of the patients with MRD low risk continue to do well in acute lymphoblastic leukemias. Medium risk are in between, and those who are in the MRD high risk group, they do poorly. This we know that, and that is. But the other part of the story is that even those who have day 15 MRD negativity, still we have not been able to decrease the overall maintenance period in this group of patients, making it very important that the maintenance is an important aspect of ALL therapy. On the other side, if you can see here in acute myeloid leukemia, Dr. Prashant talked about it, and others also talked about it briefly. But as we all know, even in AML now, MRD is becoming an important prognostic marker. But as you can see here, this is not as important as in AML, as in ALL, because you can see here that even those who are MRD negative, they continue to to relapse, and maybe the outcome is not as good as for those who have MRD negative with ALL. Stressing the fact that after, what it shows is that after the induction therapy, after the initial therapy, if there is no good therapy to continue with, maybe still the MRD may not be that strong a marker. And in ALL, when we have good maintenance therapy, these patients continue to do well, and that's why maybe MRD low continue to do well even after the initial part. And in AML, they are not doing that well as in ALL. So definitely shows that we need to have some good therapy after the initial therapy, even for this in this group of patients. And that is why now we know that initially there were not many options for us, but now, as we all know, there have been many new options which are available to us. And as we all know, the gemtuzumab, the anti-CD33 antibody, now is available, and especially for the low risk group, this antibody may be a good therapy for those who are MRD positive at the end of initial treatment. Then we have now epigenetic modifiers like decitabine, azacitidine, as well as basically uh, the histone deacetylase inhibitors, veneto, the tyrosine kinase inhibitors, the FLT3 inhibitors, especially the newer one which are coming up, and certain drugs like we just heard about the venetoclax, which is a BCL2 inhibitor. These are drugs which are showing really good results, especially in the adult AML. But maybe these are the drugs which will be available to us shortly, even for the pediatric AML. And therefore, as we all know, in ALL, as we know, many of the concepts that have come from pediatric groups have been translated into the adult groups. However, many or most of the principles that we have been using in acute myeloid leukemia have been coming from the adult group. And this is just to show you that the standard of care, the AML 3+7 therapy, as was the standard of care till recently, and this was being used in most of the adult protocols. But this is one of the recent, the reviews reported from the MD Anderson Hospital, which is basically they're showing that for therapy for younger AML at the MD Anderson in 2020 plus, as you can see, they have really changed the way, and 3+7 is no longer standard of care, and many of the patients, along with venetoclax, FLT3 inhibitors, etc., not only get the continuation of therapy, but as you can see in the last line, they get up to 2 years of maintenance therapy after the initial therapy. That means now most of the patients, younger patients especially at MD Anderson, not do not stop the treatment after the initial 6 months, but continue to get up to 2 years of treatment. And this is what we have been talking about at the Tata Hospital since last nearly 20 years again, where we have been using metronomic maintenance therapy, which is oral prednisone, etoposide, thiaguanine, which have been using since many years now. And just to show you the good responses that we have seen in this with this therapy. But very importantly, we at that time had told that this type of therapy needs to be evaluated in patients whose general condition is too poor to start standard chemotherapy, patients who need time to arrange funds, especially in a country like India, and very importantly, to use this type of metronomic therapy as a form of maintenance therapy, especially in patients who cannot go for allogenic stem cell transplantation. And this was the protocol that we had used, where the standard, basically 3+7 induction therapy. We do the date and marrow at our institution, and if the date and marrow shows more than 5% blast, we give them sequential induction with cytarabine, which is not the typical day 135 cytarabine, but 2 grams per meter square 12 hourly for 4 doses. That is total 8 gram of cytarabine in 2 days. And this is followed by, and for those who are day 10 low bone marrow blast less than 5%, and after the sequential therapy, they get the standard consolidation therapies with high dose cytarabine. And then we used to give them 6 months of oral maintenance therapy. And this, if you see the the outcomes of these patients, basically we saw that around 9 patients had a blast more than 5%, and these patients got the sequential therapy, or 9 or 17%. And very importantly, I'm not showing the data, but this is the group of patients who did the best. But overall, if you see in this group of patients, the disease-free survival was around 70%, and this was nearly 15% better than what we had reported before without using this type of maintenance. So definitely the maintenance helped us in this group of patients, and since then we are using maintenance therapies in our AML patients even to date. And this is just to show that there are many new directions coming out for the acute myeloid leukemia therapies, especially in adults. But I wanted to stress on the fact that even years back when I was doing my residency, Basically, the acute promyelocytic leukemia was one leukemia which was dreaded upon by residents because we had to really do a lot of supportive care, platelet pheresis and all. And even with all that intensive therapy as well as bone marrow transplantation, you can see the results from the Memorial Sloan Kettering, which were around in the range of 40-45%. But the same leukemias now with not even any chemotherapy, just with oral, now that arsenic is also available orally, arsenic and etra, if you see oral therapy without any chemotherapy, we can see we have more than 90-95% long-term survival in this group of patients. So definitely we do not need intensive therapy or stem cell therapies to improve the outcome. What we need is the proper or the appropriate therapy, and this may change the way we are doing are taking care of our patient. And just to show you the results published again from MD Anderson, where they used the triplet with venetoclax, FLT3 inhibitor, and decitabine. And this is just the preliminary data, just data in maybe 12 patients. But you can see here that they have 80% event-free survival in our overall survival in this group of patients without using any aggressive chemotherapy. So definitely it gives us a lot of hope that in the future, such type of therapies may become important even for patients with myeloid leukemias. And this is just again some preliminary pediatric experience using the same drug. And again, they have shown that most of the patients who got that had a good MRD negative remission with these therapies. And that is why it shows that, you can basically see here that we will start with something like hypomethylating agents plus venetoclax, and then add on the other inhibitors depending on what type of the aberrations or the genetic defect the patient has. But overall there will be addition of such agents, and maybe once we get to low MRD, immune based therapies may be added, and consultation with again immune based therapies. So what I propose is that basically we have gone with this, we have come at the crossroads, but now it is time to take a U-turn or 180 degrees turn and change the therapy with the fact that we start with induction therapies as per the acute leukemia, whether it is ALL or AML, but post-induction, maybe most of the patients with AML also will require maintenance therapy. And like it had helped us in taking care of a patient with ALL, maybe in AML also will be able to improve the outcomes in this group of patients. So that's my last slide. So thank you very much. And I know this is some not the standard of care, but maybe some thought for consideration. Thank you very much.